So myasthenia gravis is under an autoimmune disorder. It's a neurologic autoimmune disorder. This is not a primary condition, meaning you don't just get it. You get it as a consequence of something else. So what happens here? The patient has an autoimmune disorder. Let's look at the normal function first of, let's say, what makes me able to do this, or like pick my nose. What makes me able to do that? Okay, so there are two sets of neurotransmitters here. One is acetylcholine. Acetylcholine is a neurotransmitter. And in order for this substance to go from one nerve to the next at the end of each neuromuscular junction, it has to be received. Okay, so let's say this is one. Okay, so here, this picture you're looking at is at the neuromuscular junction. This is a nerve here, right here. These things are nerve endings. Okay, so this is the end of another nerve ending. So this is the acetylcholine, and these are the acetylcholine receptors. They have to be received. So each acetylcholine molecule must be received by a receptor sites before it can be transmitted to the next nerve ending. The next nerve. Do you follow? Meaning these are lightning speeds, okay? So these transmissions are, imagine, I can just pick up my hand and then choose, automatically which finger to use to pick my nose, right? And take something out. And this process continues with every muscle contraction. So we've got acetylcholine receptors. As long as the amount is balanced, meaning you have you have an equal amount, well, not exactly the same, but you have adequate, let's just say you have adequate acetylcholine and adequate acetylcholine receptors, then the patient, the person can do any purposeful movement. Okay, so right now, so I'm touching this, okay, I'm touching my hair, so I can do that, okay, because I can sustain the activity because I have an adequate amount of acetylcholine, adequate amount of receptors. All right, so everything's good at this scenario. However, the problem here becomes, what if I develop an antibody against the acetylcholine receptors? So now I have enough acetylcholine. What I don't have are the receptors. Look at the illustration on the right. So now your autobodies, your auto antibodies destroyed the receptor sites. So you don't have enough. You still have some, but not enough. There's nothing wrong with your acetylcholine. You have enough acetylcholine. There's just not enough receptors. So therefore, the transmission, is it smooth? Is it continuous? No. So what will happen? Am I able to sustain the movement? I cannot. So this one will particularly cause weakness and fatigue. Okay, so I cannot sustain, especially repetitive movements. Now, name common repetitive movements you do every single day. That you do over and over. Walking, blinking your eyes, talking, right? Or during a meal. How long does it take you to eat a meal? Okay, let's say 10, 30 minutes, right? Is that continuous? Is that a repetitive movement, like chewing and swallowing? Yes, that's a repetitive movement. Can you sustain that if you have this condition? No. So could you choke? Yes. Do you have enough energy to finish your meal? Can you work a job? No, because you have repetitive stuff you need to do, right? Let's say you're an RN. Can you do your job with this condition? No, there's always someone calling. There's patient here, patient there, orders here, medications there, right? So we have repetitive movements, muscle movements, I mean, that we need to perform, and we cannot do it if we have this condition. Any questions so far on what's wrong with the patient? Okay, so again, it's an autoimmune disorder. you develop, do we know what causes autoimmune disorders?
No.
No, we have no idea. So it's just unfortunate that you have antibodies that destroyed your acetylcholine receptors. Okay. So what will be manifestations? Let's start with the eyes. So we have blinking, right? Blinking is a repetitive movement. We're not aware, but we actually blink how many times per minute? Not really thousands, because I don't want to be doing this. So, like how many times a minute? At least, right? At least 10, probably 20 times a minute. We're not conscious about it, but we are. Yeah, we are blinking. So that causes us, what's the purpose of blinking our eyes? To moisten and lubricate the eyeball, right? So if you're not doing that anymore, because that's a repetitive muscle contraction, you can't sustain that. So what happens to your eyes? Hey, dry, red, itchy, right? Painful. So the patient will have eventually diplopia, which is double vision. They'll have ptosis, which is eyelid drooping. You look like deputy dog. Then you have your bulbar muscles. Now, bulbar muscles are the muscles involved in chewing, and swallowing and speaking. So these are the muscles of your cheeks and your jaw and your throat. And then going down, this will also affect your breathing muscle. Your diaphragm will be affected, although not as bad as Guillain-Barré syndrome, but there is some respiratory weakness here. All right, so there's weakness everywhere, okay, especially the bulbar muscles and then your respiratory. Then how much more your leg muscles? So can these people sustain walking or jogging or commuting? No. Okay, so they'll have weakness, severe weakness. So we need they need intervention. Okay. Now, first scenario is the patient has not been diagnosed yet. So these are their symptoms, right? So they have these manifestations, the ptosis, the difficulty, they can't finish a meal, they get tired easily, they're having difficulty breathing. All right. And then they call someone, okay, they're taken to the doctor or to the ER. Now, what the doctor will do first, since this patient has never been diagnosed, therefore has never been on the treatment. Oh, I forgot one more thing. Let's finish this one. So the physiology is, imagine a scenario wherein you have acetylcholine all the time. There's still negative feedback here because do you need to continue the task forever? Are you eventually going to stop? Are you eventually going to sleep? All right, so we need something to control the amount of acetylcholine, right? So we call that substance acetylcholinesterase. This one. Acetylcholinesterase is another enzyme that will destroy acetylcholine. But this is totally normal, right? So we have acetylcholine, we have acetylcholinesterase, which will destroy it. That way, we can stop the movement, right? Because otherwise, can we ever stop the movement? No, as long as there's acetylcholine. So we need to stop it eventually, and that's where acetylcholinesterase comes in. All right.
So that destroys acetylcholine.
Correct. Normally, okay? So normally, so that we stop the muscle contraction. Otherwise, that muscle will never stop contracting. All right, so that's how our body works. Now, you have these symptoms again. Doctor has his suspicions. You fit the clinical picture. Okay, they say, oh, I've seen this before, but let's make sure. Okay. So what the doctor will do is they'll give you a Tensilon test. Tensilon. Tensilon is the brand name for edrophonium chloride. What is edrophonium chloride or Tensilon? This is an acetylcholinesterase inhibitor. Meaning, what will this do to acetylcholinesterase? Inhibit it from being released. Okay. So if there is no acetylcholinesterase inhibitor, there is no acetylcholinesterase because you gave an acetylcholinesterase inhibitor, which is edrophonium or Tensilon. What will happen to the amount of acetylcholine? increase. So they'll hang around longer, right? At the neuromuscular junction. They're not destroyed, so they'll hang around there. So remember, the problem with the patient is what? They don't have what? Not enough receptors. So the theory is if you don't have enough receptors, but let's say if you keep the acetylcholine around longer because you stopped acetylcholinesterase from destroying it, can you now sustain the activity?
What?
Yes, that's the theory. Because there's an imbalance, correct? So we don't have receptors, so there's a backlog here. So we have enough acetylcholine, but not enough receptors. So that's why the weakness comes in. So the patient manifests the symptoms of weakness. Plus the fact that acetylcholine is normally destroyed by acetylcholinesterase. So if we give a drug that will inhibit acetylcholinesterase, which will therefore not allow acetylcholine to be destroyed, will there be now enough time? So even though you don't have enough receptors, but you're not destroying the acetylcholine, so they hang around longer enough to be received by the remaining receptors, correct? So now if we give that drug, what is the expected response if you have myasthenia gravis? The response is okay, the patient's strength will improve. Okay, within 5 minutes of, within 30 seconds to 5 minutes after injection of edifonium. Do you follow? Okay, so if you have improvement of muscle strength after the administration of the edifonium or Tensilon, then that is a positive Tensilon test. Do you follow? Any question on the testing? Okay. So Tensilon is edifonium chloride, and it is a acetylcholinesterase inhibitor. However, this drug is only used for testing because it only lasts for a few minutes. It is not long-acting. It only lasts for a few minutes. So can we use this to treat the patient? Because if we use this, that means the patient will have to have a infusion 24 hours a day. Make sense? Okay, so we can't use this for treatment. We can only use this for testing only. This the only purpose of this drug is to test for myasthenia gravis. We'll come back to atropine later because I'll take you to the crisis first and then we'll come back here. All right. We'll talk about Tensilon again because there are two purposes of Tensilon testing. One is to diagnose first-time diagnosis of myasthenia gravis, and then the other time we use Tensilon testing is to distinguish between two different types of crisis. Okay, so therefore we know we did the testing. It was positive. The patient had improvement with Tensilon. So the patient's diagnosed, oh, you have myasthenia gravis. The patient will say, okay, now what? Okay, so we'll put you on medications. Okay. So the treatment will be anticholinesterase inhibitor medications, but these are now long-acting ACH inhibitors. You can also use immunosuppressive therapy. There are two options, either IVIG. This is the infusion of immunoglobulin. Do you know what is immunoglobulin? This is a concentrated bag of antibodies. Why is it given to the patient? What's the nature of the problem? What did the patient have? Autoantibodies, which was destroying their acetylcholine receptors. So if we give them good antibodies, will that suppress the bad ones?
Yeah.
Yes. It's expensive though. This is sold per gram. Last time I checked, it's about $1,500 per gram. The dosing is based on your weight. It's so many grams per kilogram. So one infusion can run you about 20 grand. Yes, insurance covers it, but remember, Obamacare was was dropped. Okay, so it was weakened. So now, do we have a lifetime cap now for our coverage? Actually, we do. Unlike Obamacare, it eliminated the lifetime cap, meaning there was no limit to how much the insurance company will spend on you. Okay, that was one good thing about Obamacare, among others. But since the Congress weakened Obamacare, now there's a limit. There's a cap to your lifetime coverage. Meaning, let's say they cap it at $5 million. Once you reach that 5 million, they won't pay anymore. You reach the quota. Make sense? All right. So just imagine, okay, IVIG, and you're not getting one infusion. This is a few infusions a week, and you will have attacks of this one because this is a chronic condition. So every time you have an attack, you'll be given the infusion. So that can add up, right? Imagine 20 grand per, at least, okay, per infusion. So it's a lot of money. A cheaper alternative is therapeutic plasma exchange. Imagine hemodialysis. What did we do with hemodialysis? We put needles, and then where did the blood go? Into the machine. And what did the machine do? Remove waste products and remove water, remove medications, whatever, right? So it cleaned and then returned the clean blood to the body. So this one, since this is plasma exchange, what is the machine removing? Plasma. Why plasma? What's the patient's problem again? Autoantibodies. Where is that located? In which part of the blood? The plasma. So does it make sense? So we will remove the patient's plasma, give them somebody else's plasma, which does not contain the autoantibodies. Make sense? So any question on IVIG plasma exchange? All right, so the third one is thymectomy. In a small percentage of patients with myasthenia gravis, small, I mean like 10% or less, they discover that they have a tumor in the thymus gland called a thymoma. If that's the case, they'll remove the thymus gland and that somehow improves the symptoms. Okay. Sometimes it's long term, and sometimes it comes back. So it's not available. Plus, not all patients again have the thymoma, right? So these are the three possible treatments, and of course, the long-term treatment is anticholinesterase medications. So this is the mainstay, pyridostigmine. There is another one, which let's say this patient's admitted in the hospital, because this is PO. This is a pill. If the patient's unconscious, then we can't give pyridostigmine, can we? No. So therefore, you can give neostigmine, which is available in IV. So patients who are intubated, for instance, unconscious, NPO, instead of pyridostigmine, we have neostigmine. So just type in NEO and then stigmine. So that's the IV form. So this is the first line of therapy. Now, how much the patient is taking depends on the patient's activity. So will me, let's say my only activity is like here, I walk to the train and then come up here and then talk. Versus someone who's, let's say, David Beckham or Lionel Messi. Do we have the same dose if we all have myasthenia gravis? Who will take more? Okay, Messi would need more, right? So therefore, the dosing, since this is adapted to the patient's activity level, is it possible to take too much or too little? Absolutely. So it since patients adjust the dose depending on their activity, there's a possibility that there will be times when they will take too much or not take not take enough of the anticholinesterase. Here we've got side effects here. All right, so let's go now to what will happen if, let's say, steroids can also be used. Makes sense, right? Because this is autoimmune. Okay, so they can use steroids, or they can also use other immunomodulators like this one, azathioprine. This is also used in multiple sclerosis or in no, it's not psoriasis. Rheumatoid arthritis also patients, because that's also autoimmune, so they're also taking that drug. All right. So IVIG can be used short term to treat exacerbations, meaning flare-ups, or the plasmapheresis. It's or, okay? They're not going to use both IVIG and plasmapheresis. Doesn't make sense because they have similar effects. So the patient's provider will just choose, okay, which one, IVIG or plasma exchange. Look at the effects. So if you get IVIG, and this is infused a few days to a week. So this what I mean by it's a lot of money. And then they last, is it permanent? About, okay, buys you about 28 days, okay, of symptom free. And these are some of the complications, although these are not common. Okay. But if you do get them, then these are the complications related to IVIG. Now for plasma exchange, so imagine first what's in plasma. So we know it contains antibodies, but is that all that's in plasma?
No.
What else is in it? Protein is in it. Yeah, albumin is in it, which is protein. It's mostly water, right? So 70% water. No, there's no electrolytes there. Clotting factors are in there. What else? So it has mostly water, albumin, antibodies, and clotting factors. And there's some glucose in it too. All right. If we remove it, what will happen? Can you clot?
No.
So you'll have bleeding problems, right? So since it's mostly water and protein, what happens to your blood pressure? You removed it. Hypotension. It has antibodies in it, but are all antibodies in it bad? No, there were good antibodies in there too. So you remove them, so what will happen to the patient's immunity?
They'll go down.
Okay, so you're at risk for infection. And then the other complications related to this is the site related. Remember, we use needles here. We use a fistula, we use a catheter, all right, to perform the procedure. Thymoma, like I said, it's only a small portion of patients. It's a minor surgery. There's really nothing special to it. They give you a local anesthetic, they remove it. Couple hours surgery. Let's go now to the complications related to not enough or too much anticholinesterase medications. Okay, first scenario is, what if I don't take enough? We call it a myasthenic crisis. What's it called? Myasthenic crisis, because I didn't take enough anticholinesterase medications. Now, the problem here is in myasthenic, and then the other problem is called a cholinergic crisis, which is the opposite. Cholinergic crisis is if you took too much, right here. A cholinergic crisis is caused by over medication, right? In both, though, it's almost impossible to tell apart. There's some subtle differences, like the salivation, for instance, is one of the differences, but clinically, when you put the patients, let's say one patient is in myasthenia crisis, the other is in cholinergic crisis, they look the same. Okay, they're both extremely weak, having shortness of breath, almost in respiratory arrest. So you can't tell them apart. Here comes the other use for Tensilon. Now we're going to do Tensilon testing again, because we're going to differentiate, is this a myasthenic or is this a cholinergic crisis? What is myasthenic crisis again? Not enough. Okay, so what will happen to this patient if I give this patient Tensilon or edrophonium? What is the expected response? They will improve, right? Their strength will improve. Okay, so which means what kind of crisis is it? Myasthenic crisis. The other scenario, remember, myasthenic crisis, cholinergic crisis, are they different? I mean, clinically, the patient looks the same. Now, what will happen if they're in cholinergic crisis? The doctor doesn't know that. He's doing the Tensilon test to find out. What will happen if it's a cholinergic crisis, which is over? What is this crisis caused by? Too much. Now, what is edrophonium? What is Tensilon? What is Tensilon? It is a anticholinesterase medication. Remember, in cholinergic crisis, you took too much of that already. Now you're going to add more by doing the Tensilon test. What could happen to this patient? Go into respiratory arrest, go into coma, or even die right in front of you. So let's go back here. When doing a Tensilon test in that scenario, what should you have ready? The antidote. The antidote is atropine, which is an anticholinergic. So if the patient goes into like the symptoms worsen, let's say the patient totally stops breathing, now you administer atropine. And as with any other anticholinergic, what are always side effects? Okay, dry mouth, water retention, etc. So it will reverse the effects of too much anticholinesterase medication. Okay, so because these are the symptoms of too much. If you overdose, that means you go into bradycardia, asystole, bronchoconstriction, sweating, cramping. It will reverse it. So atropine will do what to the heart rate? It will increase it, increase heart rate. So therefore, you have a rhythm. So it will raise heart rate. Now let's go to the treatment of a patient who is in crisis. So we did the testing. So we found out, oh, it's cholinergic. Oh, it's myasthenic crisis. But since this patient is in crisis, actually if I ask you, if the patient is in myasthenic crisis and I found out using Tensilon tests and we prove, oh, it is a myasthenic crisis, what do you think is the treatment for myasthenic crisis? They were not taking enough. What will we do? Actually, in a crisis, it's actually not given because the anticholinesterase inhibitor will actually increase the secretions and thicken it. Is that good for a patient who is already in respiratory failure?
No.
So initially, no anticholinesterase inhibitors at all. So we'll just intubate the patient, put them on a ventilator, then we will slowly start the dosing once the patient is more stable. Make sense? Okay, so we don't, because again, it will only thicken and increase the amount of secretions, respiratory secretion. So not just yet. So we just treat the patient symptomatically, support ventilation until they're no longer in respiratory failure, their blood gases are good. Then we can slowly introduce the anticholinesterase inhibitor. Right here. So cholinesterase inhibitors or anticholinesterase agents are stopped when respiratory failure occurs and then gradually restarted. Okay? Just during a crisis. What do you think is the treatment for cholinergic crisis? Patient got too much. Well, that was for testing. So now the patient had too much, right? So do we give any? Okay, definitely no. So we still support the treatment symptomatically, intubate them, put them on a ventilator, and then reintroduce again once they're stable. Okay, same treatment. But the important thing is we distinguish between which type of crisis the patient is in. The rest of the interventions here are aspiration precautions, because remember, especially in myasthenia crisis, so the patient will have cannot sustain repetitive activity. And teaching, very important. Please read the others. No, these are related to the symptoms. So let's say the dry eyes. Okay, so these are the interventions here. Crisis, this is repeated. So here are the interventions again. So mechanical ventilation, intubation. Okay, drug therapy. So what is the advice for the patient? When should they take the medication? So here's a safety alert. So they should take the medications on time, right? So what would be the best time? So let's say I'm gonna I'm gonna have lunch at 12 noon. So I don't choke or die in the middle of a meal. When should I take the medication so that I have enough? Okay, so it's actually about 30, or some books say 45 minutes to an hour. So best would be 1 hour before a meal. That way the drug peaks in the middle of your meal, right? So that you can sustain the activity. So you can chew and swallow normally. Any questions?